I just want to quickly show you how I examine on one of you. I'll just choose one of you. So I quickly examine a cervical and another spine in terms of degenerative pathology. Then I'm not really spending much time on special investigations, but I'd rather pick that up in the cases rather than duplicate. I look at something and then see it anyway. So there are, there's actually 2 lectures in here that you'll see. So there's about 3 lectures in here, and then hopefully that's an hour, and then we'll do the cases. If it's getting too long, we can some of the cases. Okay, so the title tonight is Degenerative Lumbar and Cervical Disease, Radiculopathy and Myelopathy. So just to clarify these words, okay, because you must be very clear that you understand what you're saying when you use a word in medicine, and you can't always, not everybody understands what you're saying, but at least if you know what you're saying, you're a fighting chance. But so radiculopathy is symptoms in the pattern of a nerve distribution, okay, or of a root distribution. Okay, so in the case of cervical spine between C5 and 6, be the C6 nerve root, which gets compressed. You'd have pain in the shoulder, down the lateral aspect of the arm to the thumb. That would be a C6 radiculopathy. So it's very much in a dermatome. It might be a sensory disturbance, it might be paresthesia, it might be pain, and then of course there'd be a correlating muscular, maybe a correlating muscular involvement. So, so you must think. So I want you to think about radiculopathy. So often I get that from my registrars. They'll say C5, 6, whatever that means. I don't know. I always say, is that a level? Is it 2 roots? What are you talking about? So you must be quite specific. So when I come to my history taking and examination, if it's a radiculopathy problem, then you must be thinking, which nerve root is it? Lumbar, or if it's down, buttock pain is usually L5, it goes down the lateral calf, is it going to the dorsal root? L5. If it's buttock, but it's more medial calf, probably L4. So that's what you must be thinking when you're examining the patients. You're not undergraduates where you do this whole examination. You're doing focused examinations. For your exam, unfortunately, you still have to sort of play the game. But when it comes to practice, you do a very focused examination. You charge down. You've got to be careful you don't miss your differential, which I'm going to be talking about. But once you go down a route, and there's an algorithm that you must develop in your mind. Myelopathy implies that there's a wider spinal cord involvement. So now that won't be a specific nerve root, it'll be more global. So that's when you get the spasticity in the legs, in the upper motor symptoms that we all know about. It's more global. In the subtle area, it might be more like, dexterity issues, so the clumsiness, difficulty walking from sort of leg-like legs. Often the posterior columns go, so the balance goes. So those are subtle myelopathy. Often, what we see at critical care is at least we can diagnose, but in practice where people have easier access to care, you might see somebody that's got very subtle things. They're trying to drop their cell phone. Is it carpal tunnel? Is it myelopathy? So that's how you think. So myelopathy, whole of the spinal cord. Radiculopathy, you can generally go quite slow on. Myelopathy is obviously a bit more urgent in time. Then back pain. So again, be quite specific when you use a word back pain, and also make patients, when they talk to you, be sure that they're using the right words, because unfortunately they will use a lot of words as well, which may not, what you're interpreting may not be what they're saying. Okay. What's that thing? You may think you understand what I said, but you didn't hear what I meant, or something like that. So okay, but the back pain, I always make it show me this is back pain in the middle of the back, on the spine. If they say about back pain and it's there, that's not back pain, it's generally sciatica. Okay, so just sort that out. Back pain to me is what we're going to be talking about a lot tonight. It's degenerative of the mechanical aspects of the spine, and just like sciatica, a lot of people use the word sciatica. Mix it up with back pain, okay? Sciatica is in pain in the distribution, or symptomatology in the distribution of the sciatic nerve, which is buttock and leg pain, okay? So, and remember the sciatic nerve is formed by L4, L5, and S1. So any of those roots that are irritated in some way can give you pain down the leg in varying distributions, depending which nerve root is involved in the sciatic nerve. But it's very important to differentiate these things, because our treatments, our prognosis is far better in terms of that. Welcome, Linga.
So, there was traffic.
I know. We're in Cape Town, eh? Okay. So Just so here's a picture. Just on the left-hand side is the pristine spine, and then on the right-hand side is our what happens to our spine over time. Okay, so in the lumbar spine, the things that degenerate are obviously the disc cushions. Okay, the disc is made up very. I mean, I'm not going into much of the basic science now, but the disc is a nucleus pulposus, and it's got an outer annular lining. When I explain this to patients, I always talk about it's like a car tire. So you've got this outer lining, and then you've got the inner jelly. And sometimes the outer lining tears, it's like radial tears, the jelly comes through, it's your disc herniation. Okay, but it's a little bit more complex than that. So your discs are made up of there's a lot of activity, metabolic activity going on in there. Remember, you're getting, you've got no blood supply, so all the nutrients are coming through the disc, transdiscal, transosseous. So any problem with the end plate and Sherman's can lead to disc degeneration because the end plates are not dividing. It's bad. And this I talked last time. Anyway, this happens. It comes up in the exam. Anyway, so obviously you've got end plate diffusion. So if you get end plate changes, it can affect your discs. Okay, there's no true blood supply to the disc, but there's quite a lot of metabolic activity going on. And while there's a healthy disc, it's got proteins inside there which are hydrophilic, so it keeps water inside. And then as those proteins denature or degenerate, then your water content reduces, and you'll see that's what we can look for on the MRI scan. And obviously, when you lose that, for us, you can see it's less hydrophilic, less water there, but it's also showing that there's problems happening to the structures inside the disc and the metabolic action inside the disc. And I mean, for a surgeon, we don't need to tell you much more than that, but then it starts to have mechanical function. So you can imagine then a slightly fat tire going around the corner, sort of slides out, you know, and so you just get that slight instability. You get more loading on the facets, and I always think of this, the lumbar spine particularly, like a wheelbarrow. So you've got this tire in the front, which are discs, so you've got your two sort of prongs at the back, which go on the ground, your facet joints. And the more that your disc degenerates and you load the front, your facet joints get loaded. Remember, your facet joints are synovial line joints. They become arthritic like any other synovial joint, which so they respond with osteophytes, hypertrophy, and so they start to have more of a mechanical compression on the spinal canal, and I'll come back to that, but that's where your spinal stenosis comes from. So all these things are normal aging process. It's happening to all of us. So your discs can bulge or tear, may press on a nerve, give you sciatic pain down the leg. You can get lateral recess stenosis from the facet joints hypertrophy. So, and we're going to go through some of these things in the cases. So I'm not going to spend too much time on it. But this, once you see this, doesn't mean it's pathological. This is an aging process. A few patients will end up with problems from this. Most of us will die with it. Okay, we just die with it. And likewise, the cervical spine. So just if you look at the lumbar spine, these nerve roots come out sort of directly sort of off the thecal sac. Remember, they run down inside the thecal sac for a while and then come out. So you can have irritation more proximally, causing more distal. But generally speaking, the lumbar spine, you get the problems in the lateral recess, which is underneath the facet. It's a concept that took me many years to understand, and you basically have to see it anatomically, either on my cadaver course or in theatre, which understand, because I mean, I've even operated with some surgeons, qualified surgeons, they don't really understand where that lateral recess is, but it's right under the facet, just medial to the pedicle. It's quite a difficult area to understand, to visualize without seeing it in 3 dimensions. The cervical spine, very similar, but remember, cervical spine is the spinal cord in the center as opposed to cord equina. So you have a different set of pathologies, but the nerve roots that are coming out are still postganglionic, you know, they're nerve roots. They come out at 45 degrees, okay? So you can see they are vulnerable to these. If this is the vertebral body with a disc on either side. If you imagine looking into the disc, on either side there's a lip called the uncus. Okay, so it comes up like this. At the back of the uncus, you get osteophytosis. So there's often osteophytes at the back here or a disc bulge, and it catches a nerve root leaving the foramen. Just remember, because C1 comes out above C2 and C2 is below, your nerve root orientation is just a little bit different. That's why C45 will be a C5 nerve root, whereas L45 will have the 4 nerve root coming out of there. Okay, so just it's a little bit different because there's a C8, but there's no C8 vertebra. Okay? So the numbering just changes slightly. But the nerves come out like that, and the uncus can cause foraminal narrowing, whether it's disc or osteophyte. and we need to get there to decompress it. And our techniques tend to be more anterior based because you've got the spinal cord there. Whereas lumbar, you tend to be more posterior based because you've got big trouble in front, and at the back, you've got cord equina, you can move around quite easily. If you've got a central protrusion, which often happens from disc osteophytic complexes, it's going to hit the spinal cord. It's not as resilient, but it's not as able to absorb that pressure. So you start to get myelopathies, but you can also get myelopathy. Oops, sorry, slow. You can also get compressions from behind, such as if you settle down the disc and you get impouching of ligamentum flavum from the back, can also push on the cord at the back. And that's sometimes why we decide, do we go from behind or not? But that's the more central pathology causing the myelopathies. Okay. So I'm just giving you a very pragmatic approach to this so that you don't kill me when you come and work with me in my clinics. I have to listen to you. So you see my letter of complaint against me, Dr. Lunga, because I'm defending you. Anyway.
Very funny.
Have you seen it? I copied the email.
No.
Oh, okay, anyway.
No.
I would say no GBV in my clinic. That's all I say. Okay.
People think it's like something wrong when a patient with nuts. Okay.
Yeah. Let's ask him to leave. I'll ask him to leave. But just so you've got a proper history, because it all started with Zama telling him to stop smoking. He took exception to that. Anyway. So when we start with the history, obviously. So I mean, essentially, this really goes for any orthopedic thing. So you want to understand the symptomatology. So where's the pain? It's usually pain. Like with spine, occasionally it'll be a functional loss in the terms of like, something's not working, the foot's drop foot, but it's seldom that you get a painless drop foot. Vast majority of the time, people are going to come to you with pain, right? And then you want to know, when did it start? Is this something that's going for 2 years, or something that started yesterday? Did it come slowly, insidiously creep up on you, or bang, you bent over, picked up the computer monitor off the backseat of the car, you felt something pop in your back, terrible pain, 2 days later down the leg, that sort of difference. How severe is it? A lot of people talk about pain. Do you need tablets for it? No, so I've got terrible pain, but don't take any medication. I've been going to work all week, or no, I've been lying at home the whole weekend, couldn't even go watch rugby with my season tickets. There's a big difference in pain. And what are the aggravators? So like, what makes it worse? What makes it better? Very general orthopedic sort of questions around this. What drugs you take? Does it help? And people always tell you drugs, nothing else, nothing else. Meanwhile, it helps for a few hours, and obviously it does help. Always be wary of people doing nothing else. And in this process, when you take in the symptomatology, you're trying to understand, is this a predominantly axial back pain problem, or is this more a radicular problem? It can be both. And if it's both, which is worse? Because part of your management algorithm might be, you can live with your back pain. I'll deal with your radicular component, because the back pain has been there since you were 40 when you mow the lawn. But the new reason that you come here is the severe back and leg pain that you can't sleep with. So, this is what you're trying to strip out of your mind. You've got to elevate yourself above that sort of paint by numbers type doctor. Okay, you're trying to evaluate for this individual, what's changed? Why is he here now? Okay, and the back pain's been there forever. And then I'm trying not to get into too many anecdotes because it's a long talk, so I'm just like holding back now. But anyway, but there are lots. All of us are lots of interesting people that come with these interesting things. But anyway, so you want to get into either back pain, radicular pain, or myelopathic. Okay, you want to just on understanding their complaints, where they are on this, because it's going to change how you deal, how quickly you deal with things. You obviously want to understand comorbidities, because you might have somebody that's got back pain, but the oaks had 3 stents and the type 2 diabetic, and it's just, you're not the balance of risk, you're not going to touch him with an operation. So you want to understand that, get out the way. The point is now spending 10 grand in an MRI scan if you're not going to operate on it, him or her. Previous surgical history, quite important. It's one of the guys that had a laparotomy, you don't spot it, and then you want to do an anterior approach, and you thought you were going to do it yourself, and you get there, and it's like everything's stuck down, and you're in trouble. So you just want to know these things. And then you want to know your patient. In orthopedics, it's very important. In other disciplines, sometimes it doesn't really matter. If you've got a gunshot abdomen, you've got a gunshot abdomen. But our game, you want to know, is this somebody you're going to do a disc replacement on? Is it somebody you're going to do a single level fusion, or you're going to go and leave the other disc, which is not so bad? There's going to be some little subtleties around the people you're dealing with. How do they smoke, which has influences on union rates? What work are they doing? You've got a guy with a bit of back pain. He moves like he says to me, like, the pain's terrible, can't do anything, but he's a manual worker. He works the council. His job is like climbing up to the lights and changing the bulb. I mean, he's not going to go back to work, so then you'd rather put him off work, get that out the way, and then see if he can cope or not. It's pointless like taking him through an operation and then he comes back 3 months later, he's still filling in the forms of the disability. You know, I mean, these are just people don't think far enough down the track. I don't want to like name and shame any sort of disciplines, but I have the opportunity of working with multiple surgical disciplines in my clinic, and it does amaze me the difference that the other disciplines may apply, where they don't actually listen to their patient. They've got like, oh, there's a disc, he needs a discectomy. Not like, yeah, you know, this package, you know, is not going to benefit from the discectomy. So you've got to know your patient. I always like to know what exercise they're doing, whatever else they're doing. So now I just want to quickly take 10 minutes, 5-10 minutes to just demonstrate how I examine somebody. But Mubashir, you can come up here. So for those watching, just sit for me on the bed, please. That's your. Okay. Maybe, yeah, I just want I don't know if you can just check, is it if you've got this on your phone at the moment, but I'll just look on my laptop and just see that you can, yeah, the camera's on, but just check that it's showing what I'm doing on it. So for me, I mean, I do examinations using about 5 minutes. In my typical private consultation is 30 minutes. I book 30 minutes for a new patient. I'll probably spend about 10 to 15 minutes taking a history. I spend about 5 minutes or less examining the patient. Probably 5 minutes looking at the imaging and the state of the initial patient, and then 5 minutes telling what's going on. You know, so so you just see the proportion would be mostly on the history. So I just tell me to get out of the way. That don't be right. So if I generally examine the cervical spine, somebody comes to me and says, I've got pain, you know, doc, I've got pain in the neck, it's going into my shoulder, around it's aching in my scapula, really, I'm thinking C7 for this one, we scapula C7, it's going down the back of my arm and into these fingers. So often they'll say it's going into this finger. Okay, so in your mind you were saying index finger down the side of the arm, that's either C6 if it was thumb, or C7 if it's including the middle finger. So those are the rules that usually work. So really in your head, when you're about to examine the patient, you're thinking, this guy is probably a C7 radiculopathy, especially if he walks in holding his hand up like this because he's trying to relieve it, and he's probably got a C6-7 disc. Let me just have a quick squiz. And I'm really thinking triceps are the weak or not. Is there triceps jerk and so on? You don't want to say, you're not close to everything else, but you're really thinking like that from the history, okay? So what I do is I sit the patient like that. I mean, it's useful to undress people, ask them to take shirt off, which I don't usually do in private practice. First of all, it takes time. I don't find there's a massive benefit to doing it. I usually just say, go down to your lowest layer, like a shirt. They've got a t-shirt on, it's usually fine. So for your exam, obviously, you're going to pretend that whole game, but I mean, honestly, I don't know anybody that addresses patients. I think most people are very uncomfortable with it. So what I'll do is I'll stand in front of the patient. So I'm just going to stand out the way so you can see. And then what I do is I show the patient what I want. It's amazing. You say, look up, and they don't know what to do. You know, it's a simple command. So I just say, okay, I'm going to stand here. So, and then I'll just say, look at me. I'll say, just put your chin in your chest. And then I'll look at him and say, okay, look up at me. Look at the roof. Okay, so I'm going to flex your extension. Look at me. Chin on the shoulder. Okay, chin on the other shoulder. Okay, so we can look back at me. Ear on the shoulder. Ear on the shoulder. Okay, so we've done a whole range of motion there. For me, that's full. If you can look at the roof, get his chin on the chest, and you should have 90 degrees of rotation. 45 degrees at C1-2 and 45 degrees subaxial. If you're short and you can't go all the way, and you want to differentiate between atlantoaxial motion and subaxial motion, you can get the guy to flex forward. What you're doing now is you're subluxing all the subaxial facet joints there. Because remember, subaxial rotation is not true rotation. It's coupled motion. I'm not going to go into biomechanical concept now, but it's called coupled motion, okay? What you do is you're flexing more on the one than the other. So by flexing the subaxial spine, the facet joints maximally, the subaxial spine can no longer couple. So then any rotation you see, so you can see, I can get even at my age, I can get my chin pretty much 85 degrees there. As soon as I go down, I'm only at about 45. Okay, because I'm not using subaxial anymore, I'm using C1-2. So if you've got a suspicion about something, then that's how you differentiate the two. That's motion out of the way. Then I usually just stand in front of them and I'll just look at the shot. I usually say, like, hold your hands open, just rest on your leg. I will then just touch over the C5 area, lateral deltoid. You feel that? I just run down the outside. In my mind, I'm going now C6 onto the thumb, C7 onto the little finger, check the fingertips, T1, that's sensation done. All right. Then I'll usually say, okay, put your arms up like this, and I always demonstrate with the patient, even English patients. It's amazing under pressure, they just don't know what to do. Okay, you just say first language. So press, then I'll say resist me, I'm going to press down, you press up. Okay, now I'm doing deltoid, C5, okay? Then I'll stand up the right to say, pull your fist towards your mouth, C5, 6, push me away. Okay, a little bit weak, but anyway.
Get it free flat.
Okay, get that here. So we'll try hit C7. Okay, I'll say, okay, put your hand first towards your mouth and then push against me. Okay, and then I'll just take 2 fingers on one, otherwise they hurt you. I say, put my fingers in their hands like this. I'll say, squeeze me firmly, push harder, harder, harder. Okay, and then I go to the intrinsics. Okay, so that's my power. Then I just quickly do this, relax, and then I just do my bicep jerk. You saw the jerk there. Just relax, tap on the back, C7, and then I maybe do a brachioradialis. And then same thing here, biceps, triceps, brachioradius. While he's sitting like that, I will do the distal reflexes. So I'll just check, okay, so there you go. If I'm a bit concerned, I might lean down, don't stand in front of me, in case he gives me a kick. And I'll just check in the back, and even with the shoe on, you can see the S1. Okay, so I will do that. If I'm concerned about myelopathy, I don't always test for myelopathy, okay? If I'm concerned about myelopathy, I say put your hands out like this, keep your fingers together. Fingers together. Okay, keep them together. Okay, then make a fist. Okay, just go open and close as much as you can. Again, I always show the patient 10 times. Look, if you do 3 quick like that, don't keep going. That's looking for, I call it clench release. I don't know what the real name is, but I'll show you what myelopathy looks like, but it starts to do look like this, okay? Keep your fingers out like that, fingers together, and then you watch the little finger and you look for the drift, and it starts to do that, then you've got ulnar drift, sign of myelopathy. Usually takes about 30 to 60 seconds, and then you can relax. If you want to, you can then do the Hoffman test. Just take the second or third finger, give it a flick like this, and you look at the involuntary thumb motion. So it clicks in. I'll show you a video now. So, and I do that bilaterally, which he hasn't got. Remembering 16% of normal people will have a positive Hoffman, a percentage of people will have clonus and whatnot. Okay. So just quickly lie there to get over here. So then I would check then I just bring them up like this, and I would just check for clonus. I usually just relax, maybe just feel the tone if you're worried about myelopathy. I usually take their shoes and socks off, give a quick clonus. I'm going to show you a video now of that. Check if there's sustained clonus. 3 beats is normal, okay? Both sides, I'm not going to show you on him, but I just scrape at the bottom over here to see whether there's an upgoing plantar. And that's about all I do for myelopathy. Okay, just stand up for me again and move your. So then for lumbar, so what I like my patients to stand up, show me where their pain is. So if they were a lumbar complaint, I'll say, show me where the pain is. And you'll probably point a finger over here. Often they make a song down, so over here on the money province, over here, and then I'll just say, okay, and I'll just look at them, see their shoulders are balanced. There's no symmetry, part of my deformity thing, but it's just back pain. It's just a glance. There's no major problem. I like, I think you must touch your patients. Patients like to be touched. It's a thing. That's why I will never take our jobs. So you just palpate the intercrystal line. Then we know where you are. Remember, that's L4, 5. Drop your finger down, then you're on 4, 5. Like I did one today on a patient, I could feel the step at 5, 1 immediately. You just palpate the spinous process, boom, go to the next one. There's a step. She only had a great one, but I could feel it. It was just slim. So then you just palpate. Is this where you get the pain? And then you go right down below the intercrystal L5 is one, and often they give the positive, they give you the pain. I generally ask them to stand up on their tiptoes, testing L5. S1, testing S1 plant flexion. I do sometimes ask them to stand the heels, a bit of a show really, because most they can't really stand on the heels and flop around. So standing heels, the younger fitter ones usually can to test L5. You obviously have seen them walk into the waiting room. You've looked for the limb, you've looked for the Trendelenburg while they've been doing that. Okay, now you can lie down on your back. So then the lumbar I'll put down on the bed. And again, I just have a little look. I do just sort of make sure the pelvis is sort of roughly square, get an idea of the leg length. Just to make sure you're not missing a hip story. And then I just run my hands down. If they've got thick pants on, I give them a little bit of a pinch. You feel that. Obviously, there's something that you say, oh, I'm a bit more concerned. And if in the history you've got like a subtle thing that's taking you down a very, convoluted thing, you may want to do it a bit better. But the average guy, I'll pain the back down the leg. So there's no dead spot, so I feel, and in my mind I'm going L5, because L5 is normally lateral and anterolateral. I've got L5 radiculopathy sometimes, I can tell you, I get it there, okay? And the funny thing is I got foraminal, so DRG gets compressed in the foramen, and you get dysesthesia here. When I first got it, in the days that your favorite registrars worked hard, I did 5 femoral nails in one day in 1996, wearing a lead jacket and armor, would not be able to stand up on, they used to use it in the Greek warfare. I drank about 2 centimeters in that call, and I got acute leg pain and foraminal stenosis. And I kept thinking water was running on my leg. I kept on operating it down, there's no water there. And that's the feeling you get. So it's quite interesting. If you get foraminal stenosis, you get these paresthesia, dysesthesia, alternative. You must also listen for that when people complain. They're not nuts.
It's really, one reading that water sensation going down.
Yeah. See, that's what you learn in practice for 20 years. Okay. Now, but you must listen to your patients. I can tell you it's lifelong learning. You listen to your patients. They will teach you all these things, and then you start to get them yourself, and you learn even more. Okay, so I will just be touching here. So people say, oh no, yeah, it must be L3. This can be L5. Okay, L3 is right in the front, stops at the knee. All right. Then down here, it's very much L5. So the calf is quite useful, lateral calf L5. Medial calf to me is L4. Okay, sometimes L5 comes down the front here, but lateral calf is L5. Okay, often patients with buttock pain, you say, a little bit altered here, there's a bit of a difference here, but here there's a big difference. Lateral border of the foot, S1. Top of the foot, L5. Hallux, I give it a little squeeze, L5. Heel, S1. Ball, L5. Okay, so but in my head, that's what I'm thinking when I'm touching them. Hey, I'm going for that radiculopathy, that pattern. So I've done sensation, just light touch or as much as touch as you want. Then I'll say, okay, I'll start with the easy ones. Pull your big toe up, just hold the big toe, okay? EHL, okay, it's L5. Then I hold the whole foot. If they've done a good pull of the toe, sometimes I pull the whole foot, then I just skip the ankle dorsiflexion because they've done it already, you know. But if they haven't done a good pull, then I say, okay, pull your whole foot up, then pull it up. There's ankle dorsiflexion, that's 4 and 5. Then I put my hand here, push me away, S1, okay? Then I go over here, push me apart, push your legs apart, L5, okay? Abductors, all right? Then I'll say, if I'm really being cheeky and there's nothing really going on, I'll say, lift your leg up in the air. Okay, and I'm sort of doing hip flexors 2, 3, and 3, 4. Okay, at the same time. I want to be a little more conscientious. I'll lift the knee up and say, straighten the knee. We'll battle with this. Okay, so we've got 3 and 4 going, quadriceps. Then I'll put hand over here and say, lift your knee up. Okay, L2, 3 hip flexors bilaterally. So you've got both sorted out. Okay, then reflexes, again, it's quite easy. You don't have a telehammer. You can again, it works quite. I mean, you can just have, usually you can just see it's going to reflex. You don't even need a telehammer. Orthopedic surgeon needs nothing to practice. It's just a big theatre. Lots of kids. Okay, and then I must say, I find it such a hassle to do this, to try and it's a pain in the ass. So I was taught by somebody many years ago, I just hold the foot up, put my hand on the thing, and I just see if there's his reflex. Okay, swing his boot, even from Mauritius. See, okay. So you don't have to lift the patient up. You waste 10 seconds trying to get that bloody finger or 4 things. So then you've got reflexes done. If you're worried about myelopathy, the clonus, upgrade planters, then you just want to look for neural irritation. Okay, so your straight leg raise. So there's different ways of doing that. I mean, the simple thing, okay, so always take the asymptomatic one. You always want to control, right? So the guys who've got right leg pain, they don't hurt his right leg. Take his left leg, okay, I'll do it. Just keep the knee straight, just lift it up. Is there any pain in this leg or the other leg? Because you can get a contralateral straight leg raise with a very large disc. You pull this nerve root, it irritates the other. If you've got a big disc there, you'll get pain in this side. So it's worth taking it up, having a look. If he starts whimpering it about here, you know that doesn't belong in a clinic, ask him to leave like I did on Thursday, for example. But anyway, then you bring up this one. What they'll probably want to bend it because it's sore, you see. It's good. They say it doesn't tension for the first 30 degrees. I don't know. I think it depends how big the disc is. And then you just bring this up. Watch what he's doing here, because often they push the foot down. They're trying to relax that sciatic nerve. So just hold the foot, bring it up, and start to winch. Okay? Then they've got pain. She says, where's the pain? No, it's down here. Often they'll say, they pain the back. That's not a stop positive straight leg raise. Okay? That's because you're moving the base of the back and he's going to sore back. So then if you want to, I mean, you often, in reality, you don't need it. Okay? So then this is the leg or the bowstring. So what you do is I mean, a lot of these things is trying to catch people out. I think you don't need it. I mean, you can see that. You can see a bullshitter from the river if they walk in the floor. But so you bring this up. So there's a good pain there. You can say, okay, bend the knee, pain goes away because you relax the side. Put on my shoulder. I hold his leg. Okay. Now what I do is I bring it up until he gets pain. Just back off slightly. Just pull the foot in like that. You're just tensioning it over there. You just get to that edge where it's pain, no pain. You bring it again. If you want to, you can then press on the hamstring, no pain. Push in the middle on the subtibial nerve, bang, you get pain. Okay, so that's how you do the bowstring or sex test. A few variations on that, but that's essentially, you just get that point of just where there's pain, no pain, and then you're just playing around there by tensioning on the foot, tensioning with your finger, okay? That's for sciatic nerve. L4, L5 is one. Just lie into your belly. Then obviously if the guy's got pain into his groin or his anterior thigh, then you want to do the femoral stretch test, okay? So if you have left leg pain, all you want to do is flex it up. What they do is they start flexing their bum. They flex their bum. So you just stop that happening because that's the compensation to try and avoid the stretch on the femoral nerve. I just put a hand on their buttock. Now just lift that leg, that's all that. And they start to get the pain shooting down the front of their thigh. So if they've got an L2, 3 or 3-4 pyramidal disc, then they get pain in the front of the thigh. Just do that and they've got the pain straight away diagnosis made. Okay, back on your back. And during this process somewhere, usually when I've done the straight leg raise, so normally I do the straight leg raise, I just flex it up and I just check internal rotation on the hip. The first thing to go for hip, for the neurosurgeon, the first area you get pain is internal rotation. So if you just external rotation, internal rotation, I get pain in the groin, that's hip pathology, okay? And that's the examination for a cervical, that was fine, it takes minutes. Okay, so that's what I do, okay, move the sheet.
Then Prof, you'll tell.
Well, you see, no, I mean, I don't do that for any patient. Okay, so if somebody comes to me and say, "Oh, my balance has gone too fast," and I see when they get up and they walk, they're a little wobbly, then you say, "Okay, then I can do the cerebellar thing and do those signs." And I don't do that for everybody. Okay, no, I'm not. No, these videos seem very slow. It's on my computer. I don't know, I just ordered them quickly and I don't know why it's doing that. I think I'm going to skip past them because I showed you what happens now. I'm quite sure. So OneDrive thing seemed to be wanting to download them for something. I don't know why. I'm not going to skip past them because I explained it to you when I examined. This is just you recognize these guys. Well, this is just a clonus. I mean, but you recognize him. Top knee surgeon now. I mean, that's just a clonus. Just flex in the ears from Borman when he was a little boy. Okay. Just bank clonus. Upgoing plant as if we can get it to work.
I know, such. Thanks for blocking.
For the first time on Friday in my life, I had clonus of a buttock. I positioned the patient on the table for surgery. The buttock had sustained clonus. Okay, so I'm going to leave those things. I'll explain to you. I just keep moving. So, I'll back on TV. Okay, so then special investigations. Now, this must be an active decision. You know, if a guy comes to you and he says, "I mowed my lawn on the weekend, I got sore back pain," it comes and goes, you don't have to investigate him. Okay, no loss of weight, no constitutional things. Give him some anti-inflammatory, see how he goes. There's no reason to even x-ray him. Okay, remember, x-rays cost a few $100. So just, I mean, it must be an active decision. It like drive me nuts with the neurosurgeons in my clinic now. They do a full spine MRI. I mean, why? You know, a full spine MRI is about 25,000 Rand. And I mean, okay, it seems free for us here. It's hardly free because it takes, this MRI takes a certain amount of time per sequence. So the more sequences you do, the more other patients don't get an MRI. So just think about it, okay? And when you get into private practice, you'll see Morton partners always want to do a contrast scan. It's extra 10 grand, okay? You only use a contrast scan when you need a contrast scan. Most of the time you don't need it, okay? Blood as well, you know, most of the time you don't need bloods for these things. It's a degenerative thing. If there's a red flag, the guy's had a fever, lost of weight, fair enough, full blood count, do your thing. I'm not even going to go into the red flags, it's undergraduate. But, you know, most of the time you don't need bloods. Don't skip the x-rays. If you're going to, if you've been down the physiotherapy, you've done the non-operative thing, don't just jump to MRI. We see a lot of that. You miss information. MRI, the x-rays of a lumbar spine is $400. It's worth the expense in somebody you're considering surgery. Don't jump to an MRI scan, because even for a discectomy, there might be a reduced listhesis on the MRI. Remember the MRI, you lie flat on your back and you think, this is just a simple discectomy. Meanwhile, there's a listhesis that you're not picking up. So get the x-ray. I just do an erect lateral lumbar and a supine AP. Supine AP, because you're lying on your back, you flatten your lordosis, you get a better view. If you do an AP erect, I'm giving my lordosis, so you're not getting an AP of my L5. You won't see my L5 as well. It's different to deformity where you want weight loading. Remember, with the degenerative, you just want to see the pathology. We're going to come back to the signs of these things. MRIs is a mainstay of spinal surgery. You basically can't practice spinal surgery without it. CT is like on demand. Okay, so that's a special case, more for things like when you're trying to delineate bony anatomy. We've got a few examples of those coming up. Bone scan be dead in the water. I think it's just a waste of money. And then we used to use it when I was a registrar here because it was cheap. It's not cheap. It's invasive. Private is about 25,000 Rand for a bone scan. And the information is really limited. Some people say, but you get a CT with it because you normally get a SPECT, single photon emission CT. That CT is a very low resolution. It's not the same as a normal CT scan. Lumbar spine is about 3-4 grand private. And the technician bone scan is 25. So they're expensive things. You think for some reason we think they're cheap, they're not cheap. Okay? So really, it's for special case where for some reason you want to know if the pars intercticularis fracture is hot or not. If it's active. But actually on the MRI, you can see all those. So I really don't have a role for it. So I'm going to give 2 talks on differential diagnosis because I think at your level, and I don't mean it in a demeaning way, but when you're going to practice, most of you are not going to do spinal surgery, but you will see patients with spinal complaints. And so this is just a differential thing because of arm pain, because people don't come to you with cervical radiculopathy. They come with arm pain, okay? And shoulder and neck pathology frequently coexist. And this is where a lot of patients get mixed up. Most patients you see are going to have MRI changes. So if a patient comes to you with an MRI, there's more than likely going to be evidence of degeneration in the MRI. But what is the significance thereof? Are there many causes of arm pain? And the problem is we get into our little silos. I mean, you notice if you turn left in D6, you get put on chloroquine, you turn right, you get a shoulder decompression. You know exactly. So you need to have a wider differential and to avoid incorrect diagnosis, incorrect surgery, poor outcome, okay? And I love this thing that was ascribed to a guy called Nickel, who was a surgeon 100 years ago, but you diagnose what you know, which is why you must read and learn so you know lots of things, and you find what you look for, okay? So, just keep looking. I don't know why this thing's on a timer here. Anyway, so I've spoken about those things already. Okay. So just ask about, say, I call this neurosurgeon's trap, because I know neurosurgeons in the room when I go to this talk, but the thing is, the neurosurgeons don't deal with subacromial decompressions very often, so that's why they don't learn about it as registrars. That's why we're trying to teach them that. We're lucky because we do see that pathology a lot. But just ask about overhead activity because that'll exacerbate shoulder problems. I always there's a screen, just ask patients, I forgot to do it on Google Show, just get them to put their hands behind their backs. Okay, because if they can do this, then it's a shoulder pathology. I get just about every second week I inject the shoulder in the spine. Patient comes in, even at an MRI, look like some registrar wants us to take it to theatre and just get your hand up. Go on, get there, and then I just inject them and I discharge like this. Okay. And you can ask about things, brushing your hair, the ladies will battle with it. Okay. Interesting thing is, if it's shoulder pathology, you get pain on the side you sleep on. If you sleep on the right, you get pain on the right, that's usually acromial problems. If you sleep on the right, you get pain on the left, it's usually cervical, because your head on the pillow gets pushed up and you close down. It's the other thing I forgot to do, sorry, is a spooning test. So the spooning test is when you just take the head back slightly, downward pressure and push. I don't like doing it, I must say. I do it for the registrar training, but patients don't like it. They come with pain and you go push it down and cause arm pain. But if you're unsure, you can take the head back and it gets pain down the arm. So ipsilateral pain when you sleep, usually shoulder, contralateral pain, usually neck. Obviously, the neck usually has associated sensory changes. Oh, here's our spooning, okay? So you'll recognize 2 junior doctors there. See where they all come from. I go first to them all. Okay, so there's Clive doing a spurting on Duncan. Okay. And also, veno-humeral pathology can radiate down the arm. I've had many patients over the years that come with pain in the shoulder down to the elbow, and it's rotator cuff pathology. Okay, don't be fooled by saying, oh, because there's radiation, it's definitely neural. It can be. I mean, the same with the leg. Hip goes down to knee. These things, that's how it works. So every patient needs a quick screen, and just thumb to scapula over the top. That's all it takes. A few seconds. I mean, if you think it's pathology for the cuff, those who don't know, you just drop the arm back, you just palpate on the humeral head, you can palpate the cuff, and often they're very tender near the coracoid of that. The abduction is limited. I usually just do they've got a painful arc, as you know, they get stuck, but I usually just do the supraspinatus test, and invariably they got pain. And then you just do a Neus injection and check again. Pain's gone. Okay, keep moving. I mean, this patient had a lumbar operation, then a cervical operation, and then was noted to have costopic tendonitis. Okay, and actually the worst pain, and he went well to the third operation, so like you wonder, so you can get, obviously, I mean, I'm not going to spend too much time on this, but there's a lot of shoulder pathology that you can get, and you need to think about it. Your elbow pain, which you might ascribe to a cervical radiculopathy, can be due to tennis elbow. So always do Mill's test, forced extension of the wrist or the finger if you want to check for a common extensor pathology, golfer's elbow for the common flexor pathology. I remember when I was a medical officer in the military, there was a very vicious hand surgeon then. He called this a telephonic diagnosis. He'd say somebody called you on the phone and said they got wrist pain. So put your thumb in your forefingers, grab it, point it down. You hear a shriek and the telephone drop, it's the curvates. So, okay, that's just the first, what's it, EPL, what's it, Brad? The first compartment, EPL.
TPO and EPL is there.
It's not important really, but there's a tendon somewhere there that causes trouble. Okay. And as with most things, the hands goes away, the good is an injection. Okay. Is it F? E? No, oh, okay. You lost it already, you peaked last year. Okay. And just remember things, local things. Just examine patients. I mean, just don't assume things. Okay. That's what patients like to be touched. It's quite useful. Prod where the pain is. I mean, this patient, he came to me as a 56-year-old man, independent diabetes mellitus, had thoracic pain, radiating to both shoulders. He had an MRI scan with he had a normal ECG and an MRI with a T5-6 disc. He sent to me at Constantiaberg when I had a practice there for surgery, because I was the only guy that was opening chests for things. And I listened to him, and when he says, I'm sitting in my car, I get anxiety, I sweat, I hyperventilate, this is more bloody thoracic disc guy. And he was using benzos and diazepam. So I sent him to a cardiologist. He admitted him, put stents in the same day. Okay, so just like listen to the story. You don't get, the thoracic radicular pain doesn't give you hyperventilation and sweating and all those things. So just, just listen. And of course, being diabetic, you have a silent infarct. Diaphragmatic irritation, you get shoulder pain. We know that. How's this guy? This guy had right arm pain. And look at his ptosis on the right-hand side. Subtle signs, These are what you must look for when you look at people. Subtle signs. Came to me at a carpal tunnel release already because he went to the carpal tunnel door. Okay. But when you look, he's shot at his X-rays. Obviously got a big lesion eroding away on the right-hand side, causing his corners. Okay. Okay. Pancreas tumor. All right. And then there's all these other things. Everywhere you've got a nerve going through a tunnel that's can be compressed. Your Guy's tunnel, cubital tunnel for your ulnar nerve, carpal tunnel we know, and then there's others that are quite rare, thank God. Pronator teres, radial syndrome, anteroosseous, interosseous. So just think, there are lots of other places the nerve can be pinched other than in the neck. Okay, I'm not going to go through all of them, but they're tons. Okay. The problem is nerve conduction studies are useless, in my opinion. They're just not diagnostically conclusive. So that's the whole barret of arm pain that you need to think about. Likewise, leg pain. Patients don't come with sciatica, they come with buttock or leg pain. And this is a classic thing you can see over here, a nice big chunky disc. This is an axial MRI. There's a nerve root on the left, just below the facet, subfacetal. You can't see the nerve root well here because there's a big chunk of sequestrated disc. You can imagine it's jammed in here somewhere. It can be foraminal. So when you look at this is a T1 sequence, okay? So we generally do sagittal views of an MRI scan, axial views, that's the bare minimum. Usually we'd like coronal view included, but I think there's a charge for 4 sequences. When you go above 4 sequences, they charge more. So you'll find a lot of the time you'll only get 4 sequences. So you'll get a sagittal T1 and 2. And I just remember T2, water, T is H2O, water is white on T2, okay? It's very simple. And so you just look for CSF. Clearly there's, the discs are also white and there's water. This is a T1. This is what a T1 looks like. So water is not white, but fat is white. So the fat is the T1 light bulb. So you see fat around the nerve roots in the foramen, fat in the bone. That's why the bones look whiter or have a higher signal on T1. And that's why T1 is very useful for looking at tumor. Because when there's tumor in the body, the signal drops because the marrow is replaced. So we use the T2 sequence. I find easier to look at, but actually T1, you just look at both. And then you get the axials, okay? But if you just look here, you can see the foramen with the nerve root in the middle. And over here at L4-5, the disc has come up squashing that nerve root. That's a foraminal disc herniation. Used to cause a lot of suicide because the old myelograms for the MRI area, they should inject dye. You couldn't see out there. So people say, no, there's nothing wrong. Meanwhile, you've got a foraminal stenosis. And that pain, I can tell you, is a terrible pain because the DR, the dorsal root ganglia of the nerve is there. It's crossed. It's a very sensitive part of the nerve root. And you can get extra foraminal. This is a patient operated some years ago. You can see this L5, this big chunk of disc out here. And the nerve root comes around and gets caught on it over here. So the big chunk of disc, you've got to open your eyes, okay? Often these things are missed. The number of foraminal discs that are missed by radiologists. That's why you have to, you must look at your own scans, eh? So we know leg pain is either local pathology or referred pathology. Hip is the most common. Professor Flock, it probably means nothing to you guys now, but he was the head of Tigerberg for a long time. Always said, spine patients don't walk with crutches. Okay, my only right that unless they want a disability part. But so neither of those belong in my clinic. But so just it's not all these things are not absolute, but spine patients aren't really benefited by crutches. Okay, if a guy's got a crutch, just check his hip out. He's usually got Trendelenburg gait. Of course, L5 radiculopathy also Trendelenburg gait, but just look at that. We taught that the hip pain never goes below the knee. That's not true. I've had patients with pain down in L5 dermatome from the hip. This is a case of point. I had this patient, she had lupus. She had clear L5 dermatome pain. Lateral calf, dorsum of the foot, hallux. I mean, did the MRI scan, it's pristine. Okay. So in disbelief, I actually repeated it, but if you look at the coronal now, you can see the heads of the femur got AVN. Okay, so this patient AVN then presented with L5 radicular pain. Okay, so don't worry. Secondly, obviously you can get all these other things. Just think about anything else can happen. DVTs, soft tissue tears. You can have peripheral neuropathy from diabetes. You can have bone neuropathy, but it's normally a glove and stocking distribution, usually upper limbs and lower limbs. Vascular insufficiency can present as this sort of heavy burning feeling in the legs when you walk. And the can be mixed up with stenosis, compression of the theca, of the lumbar theca. But generally, there's no pulses or something to work it out. Some patients will have coexisting pathology, unfortunately, and then to decide which is worse. Get the rare and the horrible. Here's a patient I had came to me with shin splits, had a primary bone tumor, adamantinoma. I only knew this once because it came up as a question on paper. But I've never seen it again in my life. And then you can have, crazy things like this. Sudden onset of right gluteal pain. You think of the L5 radiculopathy, you treat the guy with a bit of symptomatic care. 2 weeks later, developed weakness. You scan him, he's got a conus tumor. Okay. It was missed on the report.
So that's why in my head, Rob, when you were casually saying, I know with some of these patients you don't have to X-ray. I always think, what if it's that one rare case?
They come back.
Miss.
They come back.
Thank you.
They come back. So this is the common cause of root compression. You can see, this is a little picture I showed earlier of a normal canal, the facet hypertrophy. You get this I call the bikini spine. You can see the shape, what it becomes there now. And the nerve roots line those lateral recess and get compressed. And this is what it looks like on the MRI. So here's a T2 sequence, and there's your disc, there's your foramen, there's your facet joint, and as those facets degenerate, you can see the hypertrophy, and you can see that how the nerve roots clump as well. So when the nerve roots, when there's no stenosis, the nerve roots lie at the back because you lie on your back in the MRI scanner, so they drop down underneath in that CSF. Over here, you can see how they clump. There's no CSF, and that's very tight. That's subfacetal stenosis there, in the lateral recess. Here you can see a facetal cyst, sorry. So sometimes you get these big cysts from the synovial joint. Pyramidal stenosis, as we've discussed. And the cesis, I'm not going to spend any time on that because we're not going to talk about that tonight. Get away from that fast. But obviously you can get other things, I mean, it's hydrated. So that's why MRI scans are very useful. You can get metastatic neuritis, so you can get medical conditions that cause these things. I had one patient, a 12-year-old child, had agonizing pain in the S1 distribution. I scanned her, normal scan, agonizing, burning pain. And like I said, no, I don't know. I said, maybe I was going to explore her back. I don't know what to do. She had some immunocompromise. I forget exactly why she had it. I forget what. And like a day later, she broke out in this rash in the S1 distribution. Okay, so and this guy came to me at first here with an L5 radiculopathy, and you scan him, it looks like worms in his spine. No, those are flow voids. So remember, the MRI scan uses a radio frequency pulse, and it measures the return of the frequency of as the energy is released from hydrogen ions go back into their position. And if something's moved, then there's what they call a flow void. It comes as a hypo-intense lesion, and so that is indicative of an AV malformation. Yeah, and then I mean, these are like things. There's like a woman here with this was a infection. I think it was a sacroiliitis because the L5 nerve root and lumbar sacral plexus go over the top. There's an old granny. She just stepped out. I remember her well. She just stepped out the kitchen back door. There's a small step. She misstepped, and if you look very closely, you'll see there's a alar fracture, or actually alar pelvic fracture, insufficiency fracture, and the iliac, that's lumbar sacral nerves going on. Just got to stay awake. Now this was a teenager who fell off a horse, and you can see she got a little spike over there. She had agonizing pain. Every time in the water, she was sitting like this, trying to relax her nerve. Gave an epidural, indwelling epidural, moved the leg around, thought I could move that nerve root, just jammed on that spike. I went in anteriorly on her, and all I had to do is just take the upcut and push that spike flat. Thank God. Okay, I think I've had enough of that. Okay, so yeah, so you get that. All these things, I'm going to stop there. So just the same thing, just broaden your differential. We've spoken about that. Okay, so now just getting back onto a bit of management. Obviously, you must make a diagnosis, and you can't treat anything without a diagnosis. There is a period of conservative care, and for exams, you must just mention that. But I mean, by the time a patient comes to a specialist, they should have actually been through the conservative care. I had 20 sessions, said physio, you don't have to send him back to physio. And if somebody's got acute severe leg pain, I don't think physio is going to help anyway. So, appropriate care. Not everybody gets conservative care. There's some, it does irritate me a little bit when the guy, the patient is obviously morphine dependent, severe pain, you're saying conservative care. It doesn't make sense, eh? But obviously a guy comes to you and says, when I play golf on the 16th hole, I get a bit of pain in my arm, that doesn't get it, then you say, no, anti-inflammatories, play 9 also. Anyway, and then obviously we get to surgery, and just remember, surgery is a big deal. I mean, we love doing surgery. We just want to get there and do surgery, but it's a big deal to people. I mean, it's expensive, puts it in harm's way, takes it out of work and family life a long time. So you really got to consider the pros and cons. And remember, my big thing, if you don't know the natural history of your pathology, you can't advise, because you need to know, you've got to be able to at least beat natural history. You can't just give things that are the same as natural history. So the principles, I would say, before we get to the cases, are if your neural elements are compressed. So in your diagnosis, the patients come to you with arm or leg pain, and you confirm there's compression of the nerve roots. Then the obvious thing is you want to keep this. So that's like a mechanical thing. You get it. It doesn't matter how you do it, whether it's endoscopically or whether it's open or minimally invasive. The lasers don't work. I had a guy ask me on laser again yesterday, but this I think is laser. But you know, it doesn't really matter how you decompress. The technique is not that important. What is important is that the nerve is decompressed by the time. If there's a mechanical instability related to that compression, like prosthesis, you may need to fuse. If you damage the anatomy to decompress, so like for instance, we do a lot of anterior cervical surgery to clear the compression on the foramen. Then you've destroyed the disc, so you have to reconstruct it. So then you may either do a disc replacement, and we'll come on to these in the cases, or fusion. If you have to take a facet out to the lumbar spine because you couldn't get to the foramen, then you would have to fuse that because the patient is going to be in a worse position without a single facet. If there's back pain, decompression doesn't work. Look, if you've got severe L4-5 stenosis in like an 85-year-old patient who gets back pain on walking, on claudication, so their legs go sort of lame, they feel heavy, they have to sit down, and there's associated back pain. That back pain may improve with the decompression. Or there is some back pain that comes from that stenosis. But in somebody that's got severe back pain when they do physical activities, like can't lean forward to shave. I mean, typically, if you've got severe discogenic pain, you can't, that forward leaning like this is impossible. So you can't shave, can't do the dishes, might help baby. But you know, so that's quite like important for discogenic pain. If somebody seems to get pain on extension and they go back, usually it's for cetogenic pain. Small things, not that, I mean, these aren't 100% rules, but just think about it. And generally fuse those things. But just remember, fusion is a biological process. I mean, there's a difference between instrumenting and fusing. Okay? Fusion is a biological process, and that means we want that segment to grow into one solid biological mass. And we need to optimize that with general things like patient nutrition, smoking, cessation, that type of thing, and then also locally with bone graft bed preparation and what bone graft we add. I'm not going to spend too much time on, but you get other lectures on that. But there's a whole process. It's not just like get in, get out. There's a biological process, and you need to optimize that. Then instrumentation is a secondary consideration. You don't necessarily need instrumentation for fusion, okay? But you need a biological process for fusion. And when it comes to instrumentation, we generally use screws. So the common things you're going to see are pedicle screws, where we pass the pedicles down the pedicles in any part of the spine. We can do it, but more commonly in the lumbar spine. But there are also other techniques of cortical screws where we use a slightly different pathway. They have been shown to be very close to the same strength in the lumbar spine. So there are reasons you could or not use that. Then you've got your interbody fusions. Okay, so the pedicles are from behind down the pedicles. They're holding the posterior part of the spine forward. So you can imagine the lever arms are involved there. And so there is arguments to go in the anterior column. So you can get to the anterior column through the disc from behind with a posterior lumbar interbody fusion, which is 2 cages normally, with a transforaminal lumbar interbody fusion, which is usually one banana-shaped cage, needs just one access from the side. And then you can do directly from the front, which is an anterior lumbar interbody fusion. That's where you go through the belly in the lumbar spine. In the cervical spine, we're always doing anterior lumbar interbody fusion. So you go through the front. And then direct lateral interbody fusion, another option. I mean, I don't spend too much time. You basically go anywhere in 360 degrees, you can go there. So different ways of putting things in with different, we can pick those up in the cases. And then there's motion preservation. So obviously, fusing patients comes at a cost because you stiffen an area, you would increase strain at the levels above, and that may break down over time. So that's why you have one operation and another operation. So especially in the neck, so I'm going to leave it at that because we're going to pick it up in the cases. Okay, so now I've got 10 cases. We'll see how we go. The Bijou, we'll start with you. Okay, so we've got a 50-year-old female, got right arm pain to the thumb, no neck pain. So what are your thoughts around that?
So it sounds like a radiculopathy. Going into the thumb, I'm thinking a C6 radiculopathy.
So which nerve?
C6.
Okay. And which level?
So it will be 5-6.
Yeah. Okay, so we didn't know before we even look at the MRI scan. So if we see like a C1-2 problem, we're not going to say, there's our problem. You know what I mean? You know, we're now looking, we're expecting something there. Do you see it?
So I mean, I looked at these images. There There is a disc prolapse at C5-6 on the sagittal.
2, 3, 4, 5, 6, okay? So that's off midline. You see, when I'm looking here, there's no cord there, so I brought it off midline, and that's where it is. It's off midline as the nerve root's coming up. It's over here, okay? Don't know why. This is not, I think it's very subtle.
Yeah, I was about to say, because I looked and it doesn't look on that image like
You
this.
see it's there, there's a disc, there's a disc there. Because there's your theca, there's your white CSF. You see how it goes up there, you can see the dura there. Over here, the dura's come back. So that's all it is, that piece, that's disc there. The nerve's getting caught in that foramen there. So you've got a disc herniation, okay? So what you're going to do now, let's say the patient's only had the pain for a week.
Yeah, so, I mean, what I read up is that 70 to 95% of patients with radiculopathy can be treated conservatively in the acute phase.
Absolutely.
With conservative management, looking at rest, immobilization, physio.
So again, this depends who they're seeing. See, some person will be operated the next day.
Yeah.
But honestly, if there is no myelopathy, which there won't be here, and there isn't in this history, and it's simply arm pain and it's tolerable, I mean, you've got a very good chance. You've got a better chance than not it's going to settle down. And I would never know this. Okay, or at 1 week. If it's at 2 weeks and I'm not sleeping at night, I'm still using Alexia and I can't operate because of it, what are you going to do? And I say, I need you to do something.
So then the only other non-operative option that I read about is doing a steroidal
Yeah, you could do an epidural, but they so that would be part of conservative management regime. I'm quite nervous about injecting in the neck because if you can inject it to an artery, you can paralyze a
Yeah,
patient.
so it's higher risk in the cervical region. So then operative management, I read about 3 options. So the gold standard, they say, is an ACDF, and then you can do a posterior foraminotomy,
Yeah.
and then a disc.
So do you have any idea why you choose anterior or posterior?
So what I read is like if you're going to do an ACDF fusion, you're going to obviously limit movement.
So take motion away.
Yeah, so that's one of the negative. But if you had instability or multi-level, then you would more err on fusion. And if you wanted to preserve motion and you didn't have instability, then maybe you would just do a posterior foramen.
Yeah. So look, I can tell you what. So without becoming too cynical, it does depend on the environment you're working. So ACDFs are the best paying procedure probably in our spinal surgery. I mean, I can do an ACDF in 45 to 60 minutes, and at sort of general rates about 45 to 50K turnover. It just shows you disproportionate. Where you're a posterior, you probably spend half an hour to 45 minutes just setting the patient up.
Yeah.
Okay, and you get about a third of that, so you can see where and that's where the pressure comes from. The same like at the state. No, but I mean, just looking at how surgeons behave. And I can tell you, if they pay the same amount for both things and the patient had to pay for the prosthesis, it may change, you know. So I would say, but there's a foramen. I'm going to come to foraminotomies a little bit later. Problem with the posterior foraminotomy is quite destructive. In South Africa, they're quite big men, and that's what they use. To get through the muscles, it's quite a big cut, and it causes a lot more pain. They do have a lot more pain. In my hands, it's also been less predictable in outcome. But that would be you open up at the back, you drill away the medial facet, and you pull a disc out. But you are manipulating a bit now around the neural structures. It's a bit more fiddly. With the minimally invasive techniques, posterior foraminotomy sort of make a little bit of a comeback, especially the endoscopic stuff. Okay, so that's where it's come back. In South Africa, it's really not worth your while. So I think financially, which is a terrible thing to say, but that does influence behavior, and also influence behavior of the companies because you're not using a prosthesis. So suddenly, no one's interested. They're not going to train you. You know, that's what happens. So whereas, you know, for an anterior approach, lots of interest, there are going to be courses to teach you how to do it. And that's the reality of life. You just have to see that and just modify what you think about those things. So the default here would probably be an anterior procedure with the Smith-Robinson procedure, transverse incision, 4 centimeters between the sternocleidomastoid and the midline structures, 7 minutes, you're on the spine, check a level, take a disc out, but now you violated the disc. You take that, you can see beautifully, you take a disc off the nerve root, so you've got nice control, use a microscope, and then the question is, now you violate the disc, you've got to replace it for something. Your choice is either ACDF, which is a fusion, or disc replacement, okay? So up until maybe 5 years ago, maybe fusion was deemed to be the gold standard, and disc replacement was an alternative. But I think now a disc replacement in a young patient I mean, I would regard even a 50-year-old patient to be relatively young, for just terms of this operation. And a disc replacement maintains the motion, reduces the chance of other breakdown, and has been shown to be at least the same in terms of outcome, if not better in some studies than a fusion. So my default, I would say this would be disc replacement, unless there's a reason not to. Very narrow, I'm not going to get one in. I've got to do a lot of bony work, there's big osteophytes, I'm going to be wearing out. So I'm encouraging a spontaneous ankylosis, which means, because my disc replacement probably costs twice as much. Again, that's probably a false statement. In the past, a disc replacement might be 25 grand, and a fusion device, a cage, would be 10 grand. But now what the companies do, because they're under such pressure, they just charge the top, the maximum. Medical aid will pay for everything. So even if they're selling you a cheap thing, they'll charge 25, the medical aid or 25. So the disc replacement comes to 25, the cage goes to 25. That's what's happening in the market, okay? So there are some other options with the cage and screws I don't like. I think they're non-union generators. Some people, like neurosurgeons, seem to favor cage and plate. I think it's crazy. You don't need a cage and plate, but this patient now in a degenerative situation. But you can see the problem with over here. So there's a cage that's been done. The patient had an excellent clinical result. Pain, they wake up pain, okay, out of hospital in a day or two. But you can see how it subsided because the cage was a bit big. Because we came from A-lift cages and lumbar spine, put the biggest possible cage in. Now I've learned, don't put a massive cage in. Just a 5 mil will usually be okay. You're always terrified of it popping out. Never had one pop out. But I would, in my hands, I would generally do a disc replacement. That's one of the disc replacements where you can see there's ongoing motion at this point, whatever time this patient. It's a different case, but you can see this patient had degeneration level above, and that's probably why I chose the disc replacement, because I didn't, if I put a fusion there, you start thinking, must I fuse the level above because it's going to cause problems very soon. Okay, probably easy.
But would you take myelopathy to be an absolute contraindication to do a disc replacement?
Myelopathy.
Yeah, is it not?
No, it's not absolute. It's not absolute, but we'll come back to that answer. No.
Yeah, then how do you take away the dynamic component of your generator?
Well, not every myelopathy is due to dynamic component. I've answered your question because there's some cases coming up. So I'll answer it when I get those questions. So this is slightly more degenerative, but it's a similar radiculopathy. 55-year-old man, no rheumatoid, constant left ear pain. What are you thinking?
Rheumatoid spondylosis.
What's left ear?
Yeah, they're getting C2 nerve.
C2 nerve attack. Great occipital nerve, often burns. So they come to the back of the ears burning, sometimes behind the eye as well. So when you hear these symptoms, just think of it as axial pathology. Okay. You get degeneration. I just put it in this talking about, but I've had them from degenerative, degenerative case. So you get degeneration of the joint and C1-2 joint, same thing. Okay. So there you go. Any comments on that?
So that's C1, C2, there's spondylolisthesis.
There.
Yeah, there's that posterior vertebral body line is interrupted.
Between C1, C2. C2, 3.
C2, C3.
Okay, then maybe. Okay, all right.
And then, yeah, so the things I was looking for was your anterior.
I gave you that as well.
Didn't really. So I'd look for your ADI,
Yeah.
which should be less than 3 millimeters.
So is it increased or not?
I thought not.
The thing is you 10 millimeters, and so that's like a baby increase. So there's a dynamic instability at C1-2.
Yeah, sure.
Okay, that's why she's good. C2-3 is not going to give you C2 or ear pain. So C2 ear pain, C1-2. So the whole point is here is that on that static X-ray it looked normal. I agree with you. There's a bit of retrodisease. There's not, but it doesn't explain this the ear pain. So the AV flex extension, there's definitely Swiss line, which we can't really call it Swiss line in adults, but the C1-2 laminar line, you can see C1's gone forward. You've got your ADI's increased, there's no doubt it's gone forward, reduces on extension. So you've got a dynamic thing, the transverse ligament's gone, or attenuated. Called C2 pain, what are you going to do?
I'm gonna take a focus history, examine my patient.
No, operate now.
So either C1, C2.
Okay, do arm fusion. Okay, so you're going to do arm fusion. Okay, well, that's a silly. I don't know.
That's why MRI. Why is an MRI important?
I didn't do an MRI there.
You asked the question.
No, why is MRI? Yeah. Well,
You.
I think did I say why is MRI important?
No, you just asked the question. Why is MRI important?
I did the CT. The reason you do the CT is look at the bony anatomy, especially in rheumatoids, because often you get dilatation of the vertebral artery canal here. You see how small that is. If you try and run a screw up there, you end up in the vertebral artery. So I think you can look at it on CT. I did say that in one of my articles, the reviewer said that's nonsense, you must do a CT. I still maintain I can't see it on most X-rays, but CT makes it more obvious. Why do an MRI?
You're looking at the CMA.
Sometimes you get sort of rheumatoid, you get that sort of hypertrophied inflammatory tissue behind the peg that may be causing what you call it? Pannis, you get pannis, yeah. And sometimes you reduce it. In this case, it wouldn't be a problem because he was fine when he was reduced extension, but sometimes you pull it back and in fact you narrow down the canal to get myelopathy.
And the
Okay.
CT is static or was.
No, static CT. Who did I give KC to? I didn't put their name in now.
Who knows, I'm looking between.
Was it you?
Yeah, I just did it now. I'm writing with email, sorry,
Okay, 45-year-old man, acute onset of hand and leg weakness. Wrist reflexes, okay, plantar. So what's the clinical scenario? Myelopathy, okay. There's your X-ray, what do you see?
So it's a lateral C-spine. What I can appreciate, looking at this adequate number, cervical lordosis, pathology 2, 3, 4, 5, 6 looks like there's some narrowing in the.
No, but it's normal for 45, eh? 40% of 45 also going to have degen, okay? There's your MRI.
Oh, okay, so 2.
You agree with MRI patient, I'm the
Oh, yeah,
guy.
fantastic. So 2, 3, 4, 5, 6 out, so there is a gross sequestered extruded disc with the cervical stenosis compression ratio more of less than 1.4. So yeah, with cord signal changes, we can see some myelination over that cord there. So yeah, this patient.
I did say myelination.
Okay, no, okay.
It's cord signal.
Okay.
Cord edema.
All right, so then, yeah, so this is patients in trouble, we need to decompress this symptomatic psychological body minority.
How are you going to do that?
So I think it's single level, there is compression coming mostly from the anterior aspect. A good lordosis C-spine elbow from the anterior side, do a anterior cervical discectomy and let me see.
Do you think you're going to get all that disc out reliably with the discectomy?
Okay.
You notice how the disc is down halfway down the middle one?
Yeah, it's the inferior one.
Yeah.
Look, I've seen you operate, so I just imagine that all things are possible, but maybe. No, it is.
And the third one,
So maybe then we can consider a perfectment at 2, 3, 4.
Look, I don't know if you have to do a corpectomy, but all I'm saying is not every disc is the same. So like now, Moses' question about, how do you've got to think about each individual case. So yeah, there's quite a large sequestrated disc. So either you're going to open it up, and what I do is I put Caspar pins, those are pins into the middle body, you distract it, create space. And I always put them at a slight angle, so when I distract, it actually opens the back. So I always forget how I do it, but I put it in, so when they, I put them in like this, so when I put that kind of holder in, it does that, it opens the back, okay? So either you will take a hook and like a bloop, and like a big chunk will come out, the dura comes back, and it's out, or you're not sure. If you're not sure, you're probably going to have to burr away, even if it's just the posterior, the posterior part over there, you're going to have to burr that down to get in there. So disc replacement is not a great idea if you're going to do a lot of boning work there. But if I had a patient, like I've had a patient that you can see that actually is this big chunk of this. So this would be not a good one. I think this for me would be a fusion. But I have had patients where there's just been a disc herniation. It's at the level of the disc. It's a young patient, he's myelopathic. I put a disc replacement because there's not dysfunctional facets. There's no translation, no diseases. if I said any listhesis like that, I definitely wouldn't do risk assessment. I think my rule would be generally fusion for myelopathy. But if you had came to me myelopathic and there was just a single level disc hernia, central nervous hernia, I'd probably put a disc replacement. You're young, it is not this degenerative facets. Okay. So, but I would say the rule would be 95% of the time you're probably going to do fusion. You'll be safe with the fusion. Okay. Okay, fine. So that was all that. Case 4. The complicated skull. Okay. Okay, so this is a skinny little 71-year-old lady from Fishhook. And she, can you believe it, 71, was German cross training until a week before she came to see me. She had a background history of hypothyroid and no particular diagnosis, but some sort of inflammatory arthritis, non-compliant with Liverquin. And she came to me with upper and lower paresthesia and deteriorating limb function, shuffling gait, but no overt myelopathy in terms of all the signs, but shuffling gait, subjective functional change, couldn't do a cross training anymore. So there is.
Yeah, so from the history, concerns of also myelopathy, but without clear signs, right? Quite an acute history. So look at the MRI scan, there's a spondylolisthesis of C4 on C5.
Yeah. So the point here, we've got a multi-level degenerate neck.
Yeah, and multiple facet arthropathy with destructive disc there between C4 and 5, as well as some other disc involvement. You also see the cord signal changes, spinal stenosis at that same level. Yeah, and as you can see on the X-ray, also just a multi-level degenerative spine.
Yeah.
A spinal spine.
So what did you do? Old lady, a few comorbidities, probably going to be osteoporotic.
Yeah, so she's there's translation or spondylolisthesis is not as a kyphosis. I did think about it, I wasn't actually sure, but you probably need to do a dual approach, anterior and posterior.
Yeah, so look, I mean, often in life there's options as opposed to what's right and wrong. So for me, though, she's actually more than, she's hyperextended. When she's hyperextended, she's actually got quite a flat, she looks like she's coming off at a kyphosis from a thoracic spine. She's hyperlordotic at the top there, and that's why everything's bunched in. So for me, everything's digging in from the back. That's the impression I get. Yes, you could go in the front and do a multi-level corpectomy, but for that to heal in an old person is really unlikely, and you're probably going to end up with a disaster of things falling apart. So for me, I don't really want to go dig around in the front. It looks to me, I just look at it, I think if I go and remove that posterior piece of bone that's pushing in from the back, the cord's going to come back. There's quite a large area of cord signals from all the way from there to there. So in my mind, posterior is a good option here. So I went posterior, but she was bizarre. She had this like toothpastey stuff everywhere. There was something that there was inflammatory arthropathy. I wondered if it was gout. I couldn't get screws at every level. Look up, these are 3.5 mil thick screws, because they're occupying the whole lateral mass. Those lateral masses were tiny. I managed to get screws into C2. So I got this. I put no drain in. She was improving until day 3. And then suddenly I got there. Constantia was terrible and I had to practice there because I work here all day. Go there to around 7 o'clock in the evening. You find your patients now weak in arms and legs. You're incontinent. So what you can do there, see if now been all day at critical scare, you arrive there at 7 o'clock, and patient's not moving their legs very well. It's not incontinent.
Well, yeah, I need to make a plan, so you need to probably go back.
Okay, go back. You want to do
Hematoma, see if there's any.
Yeah, so I scanned it first. I can't remember the exact, if they phoned me during the day or not. I can't remember now. Didn't look at the notes, but so that's a scan. So I did do a scan. You can see she's developed the hematoma, hey? Which is strange at day 3. And the bugger, she had started her homeopathic medication post-op without telling me about it. And just remember, many of those homeopathic medicines, St. John's wort, garlic, salmon oil, are all anticoagulants, eh? So that's why I think she started bleeding. Anyway, I sucked it out. She was better at 6 weeks. Okay. We did this one. Ladder.
Probably good question on that. Yeah. I mean, I know you did it and it looks fine. Is that stable enough for like the?
Well, that you are. I think so. Yeah, I think
basically the whole cervical spinal degenerative.
Well, yeah, I think so. I mean, I only removed the posterior elements here. I wouldn't have liked. You could argue, don't you just do a laminectomy and not have it fused, but with that step case deformity, I'm a little bit concerned about it, so that's why I fixed it. But yeah, it's stable enough.
Yeah.
Look, you go front and back. You always got to look at what am I gaining and what am I risking. And I think to go in the front to do a multi-level fusion now, it's a lot more risk, minimal gain. I think if I saw that, you know, to me, there was a static deformity. It wasn't dynamic, it wasn't unstable, you know. So if I saw a dynamic instability, I'd be more inclined to go front. It could be Vabrant, who said he's having a baby tomorrow, but I believe he's had it now. This new thing about we having babies. In my day, my wife had a baby. Okay, so none of you got this case. Kim's got a case, I know. Cindy's got a case, I know. So, okay. Wasiba's got a case coming. Who wants this one? Okay, Brad said, no, Brad's not got questions. Okay, welcome. What do you see? 55-year-old man, self-employed. He said to me, he works, when he cleans gutters. And every time he put a ladder against the wall and climbed up and looked up, he feels weak, he gets pins and needles down his body. Only when he looks up on the ladder. So then I said, listen to your patient, what's happening?
Okay, I see epilateral of the cervical spine. It's like a multi-level degeneration with reduced disc space. There's also looks like an lesion that I can see on C2. And
Okay, where do you think the pathology is on that X-ray?
sorry,
Where do you think the pathology is on that X-ray?
lifting up his head. Probably C1, C2.
But on this X-ray, where you see pathology, you see pathology.
C4, C5, it looks like.
There. 3, 4, 4, 5. This one. 4, 5, 6. 4, 5, 6.
Yes, I do 5, 6.
Okay. So that's the obvious pathology on this X-ray. Do you think 5, 6 is going to give you symptoms when you extend?
No.
No, because it looks fixed there.
Yes, it looks.
So that's not the problem. Anybody see a problem with the X-ray?
Inadequate.
No, it's not. You're inadequate.
What's he got on his AP there?
Yeah.
That's like little bright sparks there by the little arch.
So if you look at this, the obvious pathology is here, but that's angular. So this is not causing a dynamic thing. If you had constant pain, you could blame it on that, but something is dynamic, something else. If you look over here, look at 3, 4. There's a retrolisthesis at 3, 4. The answer is always on the X-ray. You just got to look for it. Okay. You look at the posterior body line C2, posterior 3. There's a step there. So there's an incompetent disc, more than likely incompetent. The flexion extension views to prove it to myself. There it is. Goes away on flexion. So it's dynamic. Look at the MRI. Now remember the MRI is lying on the back in a static position. So it's got that degenerative 5-6, which we know. Now it's very tempting to go to a 5-6 operation, but I knew it's not a dynamic, it's got a dynamic problem, and that's a static issue. But if you look here, you can see there's a slight, there's not much going on here at 3, 4, but there's something on that cord. You see a little bit of signal there. So I said to him, listen, to me, it's not 5-6. It could be 3, 4, I don't know. I would suggest you do a 3, 4. And so I did a 3, 4 ALF, like a ACDF, symptoms gone. So just listen to your patient. Because really you say, oh, you've got a 5-6 ACDF, but that was never going to cause a dynamic problem. Okay. So just goes to show, listen to your patient, make a proper diagnosis. Okay. Go, Fidelis. Yes, now we're coming to something. I chose it for you. So this guy comes in, you thought he was scary, his wife was his coach, is even worse. Okay, 8 weeks, left arm numbness and pain, he got a world title defense coming up, he was doddering our Japanese people for money, so he had periscapular pain, posterior arm pain, and medial fingers were involved. So what's going on there, Dennis?
Yeah, so it's a bit confusing for me. So here the first two, periscapular pain, posterior arm pain, I thought probably C7, C8 there.
Yeah, sounds like it. Periscapular is normally C7. So that's, I'll see that. Okay, so there we go, medial fingers, so sounding like low down there. Okay, spooning was positive, big bloke, okay? I mean, honestly, when I said like, when I said like Ruben's shirt, he like pushed me away, and like lifted me up. Okay. I was unable to test his hand power because he had a KY holding a metacarpal together when he'd broken from the last fight. You know how these guys fight? I actually got a video, but I don't think it's going to play. But they hit that you only, you fight till you submit, eh? So. Or you pass out. Okay, so here's his MRI.
My scan is not very impressive, but he does have big disc at C71.
Yeah. So I think it was this one here. You see, there's the midline. There's not much going on in the midline. He's got multiple level bad disc. Not a happy looking neck for C33-year-old. As you come out, these are looking a bit dodgy. And I convinced myself 6-7 was causing the problem. Very foraminal stenosis here.
Yeah, it looks like it's bilateral there. So.
Yeah, but I think it was only single-sided symptoms, eh? Left. Yeah, so, oh, okay. So there's a left, it was there. So I said probably 6-7 is this. So what you can do about it? Let's see if this will play.
Yeah, so the problem now is with a big fight coming. So
yeah, big fight coming, lots of money. His coach, which is his wife, says they need to do the thing. I don't think it's going to work. Anyway, he's got a whole video of him beating somebody up in the ring. Okay, so what now?
Then you just consider the duration now is 8 weeks down the line.
Yeah. Can you do an ACDF?
If he's got a big fight coming, I think I'll
you can use ACDF because you can offer a year. Eh?
Wait. So I thought maybe like 3 injections, but we said a little bit too risky for the nail.
What operation can you do that's not going to destabilize him? It's not going to require fusion.
Like a foraminotomy.
Yeah.
But now also like say like for these big guys as well.
Yeah, so this was 2011, eh? So you can see there's a C7 nerve root. So you just go down onto that side, onto the lamina, just do a unilateral approach. You burr away the medial facets. I lifted the nerve root up actually with Dave Welsh. He came and basically held my hand. And then there's the piece of disc, sequestrated disc underneath the nerve root. Okay. Just popped it out, pain gone. Went on. Win. See? That's what happens when I operate on you.
What's your
Measure 2 hours. 18 hour and a half. Jeez. Okay, anyway. So there's no listen.
Take way to get back to.
They even afford to fight. They would afford. Anyway, don't forget for a bunch of foraminotomy, it is an option in a very lateral distance. Okay. So I asked him want to do this case, and sorry, I'm traveling. What's that all about? Which registrars go to the US?
Not the ones that you pay for.
Anyway, okay, so everyone didn't bother to do this case, I was too busy flying. 41-year-old male, debilitating back pain, no leg pain, completed his family. Okay, I'm going to go, I'll tell me why that's important in a minute. Okay, 45-year-old guy, I just did this guy recently. Okay, so what are we thinking? It's an axial back pain, eh? Well, anybody can talk, what do you see? It's not real, I don't think it's really a diseases, but there's obviously disc degeneration and loss of the scar, okay? Yeah, I mean, I just the only view I had, I actually said there's no movement on the picture. Here's his MRI.
Degenerative disc,
Yeah.
this variation, but
And others are all normal. So he's got this guy actually from Kimberley, he contacted me, I did a video conference with him, and he said debilitating back pain, he's a self-employed guy, runs his own business, can't play sport, battling with everything, battling with sex, and he put his pain was a little bit higher. So when I saw his MRI scans, he kept showing his pain to the mid-lumbar. So I said, no, look, you're going to fly down, let me examine you, I can't finalize this in a video conference. And then I put my finger and I pressed it, below the intercostal line, 455, and I gave a good drip there. Induced his pain straight away. So amazing what you can do just with a bit of fish like that. And I said, no, look, it's L5, it's 1. Now, what are we going to do, Scott?
yeah, well, you've got a degenerative disc. So you could do a post, you could do a
So first of all, what's the operation you do? What's the broad term of the operation you do?
so decompression and fusion.
Why decompress? No leg pain.
But there's foraminal stenosis.
So no leg pain.
Not, no,
There's got no real parameters to know, so sorry, it's a bit off cut, but I mean, the other side looks like it as well.
it's a little bit on the left there.
You just got back pain, debilitating back pain, can't get up out of bed.
So they do an infusion, but problem is that it's an L5S1, so you might have to, yeah, you might have to do quite a drastic infusion here, so maybe go from L4, L5 to pelvis even.
Why?
Correct, it's. I like to, you're getting a wicked Victoria, what's going on?
5-1 fusion, I'm going to use a 5-1 fusion, it's not a big deal, you can do it from behind, but what? Look, the reason we go from behind normally is because you want to work in the canal as well. We don't want to work in the canal. This is purely a mechanical operation. We want to stabilize L5S1. The problem is if you go from behind, you can disrupt his erector spinalis muscles. He's got great muscles elsewhere, great discs elsewhere. You're going to strip his muscles, increase the chance of proximal junctional failure. And I mean, he's young. You don't want to bug up his muscles. So what's the other option? Anterior. Okay, so what are the contraindications? Well, what are your concerns around anterior? What's sorry for that? Yeah, exactly. But he's athletic. I said, you want more children? So now I'm done. I've got 3 kids, not anymore. Because retrograde, as I understand retrograde ejaculation, it's not like it's a big deal to the person, it's just that you become infertile because it's falling backwards. But apparently the sensation is not much of a difference and so on. I mean, this is what Peter Polly told me from his patients. Like, this is tiny things up. He says, you know. But anyway, but obviously if the guy's going to have, you ask about the family, because obviously he wants to have family as proper because then they've got to go harvest. There's a 4% chance of retrograde ejaculation due to the approach because of the hypogastric plexus in front of the spine, and 50% recover. So you're going to have 1 in 50 chance of permanent. So for me, it's, I think the retrograde ejaculation is probably lesser of an issue. It's more the blooming veins. You know, you tear that vein, you end up with a swollen leg for the rest of your life. That's probably more miserable. Anyway, we did this ALIF, and that's what it looks like. It's a fantastic operation when you know, in this sort of situation, you don't get many of these people. It's young, got isolated back pain, highly motivated. It's got normal discs at every other level. And he woke up, next day said, I want to go home. My pain's gone. He was walking around the ward, gone. And you can see it takes me 25 minutes to do this because the vascular surgeon opens up. I just take a disc out, dilate, put the cage in. And then the only problem with this patient was that my vascular surgeon put a fentanyl intrathecal injection through the disc space, which should be fine. And he came back 2 days later with a flippant CSF, low pressure headache, but it did resolve on 2 days bed rest. But other than that, it's fine. But that's what an ALIF looks like. And it's got a, you know, you can just imagine the fusion rate is better. It's under compression, so all the biological factors are positive. And you know, it's minimally invasive, so a small incision to the front. So that's that. Okay, Kim. Easy one. 35-year-old male, 2-day history of right calf pain. What are you thinking?
Radiculopathy.
Which nerve root?
L5.
5. Okay, or S1. If it's posterior calf, S1. Yeah. Okay. What do you see?
Yeah, so sagittal view, T2-weighted image, you can see extrusion there, the L5.
Yeah, it's more than extrusion, that's sequestration. So
I don't know if
protrusion,
it was intact or not, when you call it.
oh, well, it can't be intact if it's sitting here behind S1. So you get, you know, bulge, protrusion, extrusion when the piece outside is bigger than the neck, sequestration, pre-fragment. Okay. What else? If I say it's got a sequestrated L5, is it disc herniation?
It's also got decreased signal in 3 and 2.
3, 4, 2, 3. It's got a irregular end plates, suggestive of grab, Sherman's type 2. Okay, but the point is, this guy's presenting, doesn't present with back pain, he's presenting with calf pain. So you don't have to do a like a skull L2 to pelvis prophylactic. What are we going to do to help this man's calf pain go away in 2 days? No, we're going to tell him to put himself together, take some pain tablets. He's probably going to get better. Okay, we're going to check his chord equina, which is unlikely to be a problem. Okay, we're not going to tell him, thank God he came in time, he's about to become paralyzed like some of our colleagues. Okay. Before you go to the ward, just kneel down and thank your Lord that you came in time. Okay. You can see a nice big chunk there. It's like a scab on your wrist. I always tell the patient, you cut yourself, the big scab, 2 weeks later, there's nothing. it heals, okay? All right, 2 days you're not going to do, you're just going to check he hasn't got cord equina, you reassure him, give him a few days work off work. But obviously, if he's crying and he's a bucky builder and needs to get back in the bucky, whatever, it might change things. But if you realize why you're doing it, because when you go in and you pull the L5 nerve root out of the upcut, and day 2, you're going to feel very sorry for yourself. Okay. But if the symptoms persist for 6 weeks or it's debilitating, I can't sleep despite morphine, etc., what are you going to do?
Yeah, so then you.
Now you're going to decompress. Okay. So what's the decompression? What are you going to do? What do you do? You're going to open the canal, you're going to remove that free fragment, enter the disc space, find the hole, flush it out. Don't remove all the disc, otherwise it's going to collapse down and get discogenic back pain. So you just take the loose fragments. There's a 4 to 8% chance of recurrence in 6 months. Warn them about that, because obviously they might stand up and it'll at least pops out. Okay, but that's very simple. Okay. Was this for everyone's one? I don't know.
No, that was.
Is it yours, receiver?
Yeah.
Okay. 60-year-old male, months of bilateral L5 nerve root pain. So what are you thinking?
Bilateral. So my thinking that probably central disc.
Could be central. Yeah. It's unlikely for a central disc to catch both L5s without causing a cord equina or more central like S1 symptoms. So what structures generally would cause bilateral L5 nerve root? Anybody? Paracesis, yeah, but a foraminal problem, like a general settling of the disc in a bilateral foraminal. So that's what you can just think about. Okay, so now we're looking.
And we have AP and lateral views of the lumbar spine. Lots of normal lumbar lordosis with degenerative multilevel lumbar disease with osteophytes 5 or L2 5 4 L2 L3 anterior and posterior osteophytes on the lateral view, as well as L5 on S1 diseases.
Yeah.
Yeah, grade 1 or 2, yeah, this is there. And then on the AP view, there is degenerative scoliosis with multi-level and degenerative disease as well.
Good. And your area of interest is?
So my area of interest will be the L5S1.
Yeah, because that's the symptoms of time. I mean, because you're going to address that scoliosis is a massive big outing, a lot of risk, a lot of sacrificing range of motion. He's come to you with bilateral L5 symptoms. That's all he cares about, eh? So focus on that. There's our MRI scan. What do you see?
MRI scan 2 weighted images, and on the one on the far left of us, difficult to really pick up because it's a static image, but looks like I would say L5S1 disc.
I'll just show. So this is the midline. Okay, you see the degeneration. Degeneration, this is probably age appropriate. But yeah, what I'm showing you is there's the body, there's the pedicle. What's the pathology here? Well, what you describe that pathology? There's got foraminal stenosis. You see there, the pedicles come down. There's a nerve root getting squashed between the disc and the inferior part of the pedicle. The vertebra's also got a slight anterolisthesis. You look carefully, the posterior elements have stayed behind. So what do you suspect? Anybody? Long-standing lysis. So it's got a lytic with subsequent disc degeneration. 6% of the population at 6 years old will have a lysis, and often it does nothing. That happens only late in life. So there's a lysis there. So that's what explains the pathology. What are you going to do for this guy?
So we need decompression and fusion at L5S1.
How are you going to decompress it?
With the posterior-based approach.
My point is that you actually need to restore this disc height to decompress. It's actually indirect decompression, because to decompress this is not just to really take out. Some guys in the past used to put the screws high in L5 and remove part of that pedicle. But the best for my hands, I would put a pedicle screw in, transport the pedicle screw, and elevate it with the interbody cage. So you lift it back up and lift the pedicle up so that you create the pyramidal height. Unless you get pyramidal height, you're not going to get rid of his pain. Okay. The other question here would be, do you address L4-5 as well? And some people would say it's degenerative 4-5, you're 4-5-1. To me, symptoms are quite clearly pyramidal, looks quite age appropriate. Yes, it's a 60-year-old disc, but he's 60. So I would limit it to a 5-1. I know he's got a very high predictability, 97% plus of obviating the leg pain, takes his chances of breaking down there later on. Incidental talar cyst, don't worry about it. Okay. Good. I think it's the last case. Who uses this? Cindy. 63-year-old female, debilitated, now got back and leg pain. What do you see?
So she has an obvious spondylolisthesis of what was L4-5?
Yeah, it's like L4-5.
Yeah. On an X-ray, so I don't see any other worrying.
So what are you saying is a listhesis at 4-5?
Yes.
Anything else about the position of the vertebra?
I didn't measure it, so I can't quantify it specifically.
Oh, you can roughly
But
say you can
they-
see it's a grade 2.
Yeah, I thought it was a grade 2. The foramen is nicely rounded like the top one, so I don't see an obvious past defect.
Yeah, which would be unusual because 4-5 is usually not
Yeah.
analytic, so it's probably a degenerative.
It's-
Yeah, but my other observation I would report is that it's kyphotic.
Oh,
Okay, so if it is it hasn't slid in the plane, it's actually become kyphotic, which is something to take into account during management. So here is your MRI, which confirms your 4-5 listhesis, your 5-1 disc degeneration. These end plate reactions are called modic, just from a radiologist's name, M with a capital M, modic changes at both levels, with relatively good looking discs at the rest of the spine. So you've got a localized pathology. So what would your thoughts be in terms of management?
So in terms of management, she's presented with back and lower leg pain. I don't know how long.
Yeah, okay, so
All
6
of
months
that.
and she's failed Pilates, myelopathy, all those things.
Yeah, so I'm moving towards surgical management. And I thought decompression with a posterolateral fusion.
Yeah, so that's why I showed this case, because she's kyphotic. And I think, kyphotic is bad because it means the other levels have to become hyperlordotic to compensate. So to give these other levels the best chance. So there's 2 decisions to be made here. Well, few decisions. I don't think you can treat it without fusion. Do you do 4-5 only, or do you do 4 to S1? I would probably do 4. I would do 4 to S1 because the other levels are all normal. And if you just do 4-5, there's a risk that you're going to have ongoing back pain. She'll complain of back pain as well as 5-1. And I think because if she had like dodgy levels at the other levels, maybe I'll say, well, I'm not going to fix the back pain. I'm just going to go for the radicular pain. I'll do 4-5. But here we've got the opportunity to deal with the back pain, even if it's only in the short to medium term before she breaks down at L3-4. But so I would do 4 to S1. I don't think a posterolateral fusion is a good option on its own because you don't want to leave it kyphotic. So I would want to lift it up, and the only way I can lift it up is an interbody fusion. And then your choices are an anterior interbody fusion with the back, but now it's a dual approach, longer, bigger cost. So I would rather do either a posterolateral interbody fusion like a PLIF or TLIF. It's a little bit above your registrar grade, but it's just thinking. There's a kyphosis, needs a little bit more. I mean, I just had to revise a patient from Zambia. They did 2 operations in Joburg, where they just simply plugged in one level, plugged in another level, and it was left in such a poor position that you keep failing, then you've got to go back and do a massive revision to recreate the lordosis. So here you've got the opportunity to, from the beginning, just to recreate. And I mean, there's a different lecture on this, but just remember that there's a relationship between your pelvic parameters, particularly your pelvic incidence, relationship between your hips and your sacrum, and the amount of lumbar lordosis you need. And you can look at that. But if you don't match the pelvic incidence and the lumbar lordosis, remembering that 60% of your lumbar lordosis is between 4 and S1. So there's a lot of things there, but basically 4 to S1 is very important. It's not like, oh, I only do base of spine surgery, I don't have to worry about sagittal balance. The bulk of your sagittal balance is determined by your L4 to S1 angle. It needs to be 60% of your lumbar lordosis, 60% of your PI. So get it, that's why I would get it right now, and give a much longer chance of a much longer solution, and maybe even not have another one. Good, that's the story.